Welcome to the Better Man Clinics, the podcast where we talk to actual experts to address the questions men want answered but are either too embarrassed to ask or simply don't know who to ask. Before we get started, I do want to caution that the conversations on this podcast are for informational purposes only. They don't represent a medical consultation, nor do they present medical advice to individuals. Rather, we hope that the podcast empowers men with the knowledge and confidence to address these issues with their healthcare providers. As with any medical or wellness issue, you should always consult with your healthcare provider before beginning any type of treatment or preventative intervention. Now, with that being said, in today's episode, we discuss sex, a topic of great importance to most, if not all, men. Specifically, we'll be discussing how men can evaluate the health of their sexual relationships, how they can identify common problems and work through those issues both individually and with their partners. And who better to help us understand sexual relationships than Kimberly Resnick Anderson? Kimberly is both a licensed clinical social worker and a certified sex therapist. Over the last 25 years, she has helped countless men and their partners achieve more satisfying relationships. And now, without further ado, I bring you our conversation with Kimberly Resnick Anderson about overcoming the common problems facing men in their sexual relationships. Hello, and welcome to Better Man Clinics. In this episode, we're going to be talking about sex, a topic that is near and dear to the hearts of many, if not most men. Specifically, we're going to be talking about sexual relationships. And as we know, guys are very critical about themselves when it comes to sex. They ask themselves questions like, how am I performing? Is my partner satisfied? And are there any problems that are occurring? And if problems do actually occur, this leads to more questions and a lot more stress and worry. And it can quickly become a vicious cycle where the relationship becomes worse and worse due to these worries and issues. So today, we are very fortunate to have a true expert on sexual relationships. We have a sex therapist with us named Kimberly Resnick Anderson. Welcome.
Thank you.
Kimberly's actual job, it is to work with men and their partners to identify problems with sexual relationships, evaluate sexual relationships, and upon finding these problems, actually work out solutions that will result in a more meaningful and a more pleasurable and a more satisfying sexual relationship for both men and their partners. So again, Kimberly, welcome to the program.
Thank you, Oleg. It's a treat to be with you.
Thank you. So before we jump into the issues of sexual relationships, I'm also fascinated. Obviously, you have a very interesting job, and
I think the most interesting job in the world, but I'm biased.
I don't disagree. I frankly don't disagree. And it is a type of profession that not many people know about, and certainly kind of in school, it's not something that's broadcast. And I'm just curious. What inspired you to become a sex therapist and kind of the path that brought you there?
Okay. Well, since I was a teenager, I've been very fascinated by the role of sexuality in our culture. I've been curious about why some people are faithful and others aren't, and all the mixed messages that we receive. Sex is good, sex is bad, sex is hot, sex is dirty. And I just have always found the topic to be compelling. So I went to a master's program in clinical social work, and I tailored my coursework as much as possible around sexual health and relationships and marriage. And then I was fortunate to complete a 5-year postgraduate fellowship in clinical sexuality at a private hospital-based university-affiliated sex clinic in Cleveland, Ohio, and have never looked back.
That's fantastic. Well, you're doing such important work because, as a urologist, I know the type of trauma and concern and lifestyle and life disruptions that sexual issues can cause in men and their partners and can destroy relationships. So very important work you're doing for sure.
Can I give you a shout out for a moment?
Please, I always like shout outs.
I'm going to shout you out.
Thank you.
It's so refreshing to see and hear that you value the role of psychology and relational aspects of sexual health. When I worked at a hospital system in Northeast Ohio, I went and spoke to the head of urology, the chair of urology at the department. And I said, I'm available to support you and your patients if they have any need for sex therapy as a result of their, urologic situation. And he said to me, why would I need a sex therapist to support me? And he was serious as a heart attack. I kid you not. And I thought, wow, it's time for me to leave Ohio. It's time for me to go out west and work with Oleg.
There you go. There you go. Well, no, it's important. It's an important point because, again, from as physicians, when we're trained, in Western medicine, we're taught a lot about organic issues, physiological issues that you can identify. They're black and white. You treat with you give somebody a medication, you treat somebody with surgery, and you solve their problem.
Yep.
And, in practicing medicine for 20 years and particularly dealing with a lot of men with sexual issues, it's not black and white. It's a lot of gray.
I like to say I can't work without your support and you can't work without my support. It really is multidisciplinary. Right. And beyond you and me, there are other specialties and areas that also have a role. So it's just good for you for making this available and reinforcing the notion that there is a relational and psychological and emotional component to sexual health. Good for you.
Thank you. No, I'm very excited for the conversation, and I think that our audience will be as well. So I want to start off with evaluation, right? Mm-hmm. So most guys are always curious about how am I doing? Right. And there's two perspectives to this. The first perspective is their own perspective. Some of them don't have the insight to see, like, how am I feeling about my own sexual relationship? Am I satisfied or not, et cetera? And also from the partner's perspective. So my first question to you is, what is a reasonable way for men to evaluate their sexual relationship? Give themselves a scorecard, if you will, to be able to get an idea of how am I doing?
Yep. The problem is, Oleg, that the scorecard is inherently flawed.
Fair enough.
The scorecard is steeped in stereotypes and unrealistic expectations and hundreds of years of notions about male sexual performance that are unhelpful. So I just want to put that out there right there. If men use the scorecard that is available to them, they're going to feel insecure. They're going to wonder if their penis is big enough. They're going to wonder if they have good enough technique. They're going to wonder if their erection is hard enough. They're going to wonder if they're pleasing their partner. And as I've come to believe more and more over the past 30 years, these things are relevant variables, but certainly not primary variables.
Mm-hmm. That's such a good point. I mean, it does have to be individualized for sure. And you want to judge yourself against you, not against the collective we, which makes it very difficult because, we run across this in on the medical side, like for instance, with testosterone levels, right? Where somebody comes in and they say, my testosterone level is low. And I can tell them, well, it's not low for you. It might be low for the guy down the street, but you're doing great with your testosterone level and not having any problems. And the guy down the street might have a testosterone level twice as high as yours, but still have symptoms of low testosterone. So I think that your point is a good one in terms of don't buy into going on Dr. Google and saying, well, find some article saying that, you know what, this is how you rate your sexual performance and you should be having your sexual activity should be lasting this long and this is how it should occur, etc.
This is how frequently you should be having sex, and this is you should be engaging in at least 17 positions, and if you're not, then so on and so forth. Yeah, there's
Right,
a
right.
lot of information out there that perpetuates insecurity.
Hmm.
And that's sort of one of my, primary missions is to um, give people a more realistic view and permission and encouragement to sort of celebrate their sexual story, whatever that may be. And even if there is a sexual dysfunction or some other uh, complaint in some phase of sexual response or some component of sexual identity, I encourage my patients to really make peace with whatever that may be.
Sure.
And I like to tell them to, invite it in for tea and let it be what it is. Not that there aren't many interventions these days. We live in a great time in terms of sexual medicine innovations. But if it has to do with gender or orientation or a kink or something, I really do encourage them to just accept who they are and celebrate that regardless of what it is.
Got it. No, that's great advice. That being said, on a high level, again, understanding the individualization, if a guy walks into your office and says, Kimberly, I don't have any specific problems, okay,
Uh-huh,
but I'm just worried. I'm a worrywart, and I'm worried that my sexual relationship isn't all it should be. And I'm
uh-huh.
particularly worried I mean, I'm doing okay, but I'm particularly worried about my partner, and I'm worried, is my partner happy and satisfied? How can I evaluate it? What anything I can do to figure out, are things okay?
Yeah, this gets complicated because when a patient comes in with concerns about their partner and
Hmm.
the partner's not present,
Yes.
there's only so much I can do because we all see through our own lens. We all have our own biases. We all have our own insecurities. So I walk through with a man. What are you wondering? What are you assuming? What is it that you think might be happening for your partner, and why do you feel that way? And then sometimes, as they elaborate, right there's things I can do to be helpful. I can reframe, I can offer a little tidbit around some piece of sexual education. um, I can dispel a myth. um, Men sometimes wonder if their partners are faking orgasm, which is a big thing that a lot
Hmm.
of men come and talk to me about. A lot of men come and talk to me about a discrepancy in desire, where they have a higher interest and their partner has lower interest. I also have the flip side of that, more than you would expect, where
Hmm.
men have low libido and their partners, whether it be a male or a female partner, are wanting more sex. I see a lot of men who are only able to maintain an erection and have an orgasm if they're masturbating and or watching porn. That becomes a requirement. So they're not able to ejaculate, for example, inside their partner during intercourse. Um, so there's just a lot of worries, a lot of concerns, and a lot of, can I trust my partner to tell me the truth? And there's a lot of resentment. I see a lot of angry men and a lot of angry women when it comes to sex.
Hmm.
So the resentment has to be acknowledged and processed before anything else.
No, that's for sure. Let's dive into a couple of those scenarios that you brought up. So,
Okay.
if a man comes to you and says, the first question is, what, Kimberly, I don't really have a strong interest in sex.
Mhm.
That's my problem, and
Mhm.
it's causing issues with my partner.
Okay.
How do you approach that problem?
This would be a great opportunity to do some education with that patient around the phases of sexual response. Because Oleg, sometimes men think they know what they mean, but they're actually talking about something else.
True.
So I'll get just a little quick example for that is I asked a woman once if she was able to experience orgasm. And she said, well, I have 3 kids, so obviously, yes.
There you go.
Right. And that's just one of many examples where someone thinks they know what I'm asking, but they just don't have the verbiage or the terminology to understand. So with each patient, I go through kind of like a primer. If you could see to my left, which you can't, you'll see I have a big whiteboard across this entire wall with all sorts of lists and bullets and examples you see here phases of sexual response and components of sexual identity and classifications of sexual dysfunction and so on and so on. So I use this board. I sort of see myself as a teacher and a therapist at the same time.
Mm-hmm.
So if someone has a question about, I don't have any dysfunction, but I'm just wondering, I would say, or if they say, I don't have the interest that I used to have.
Right.
Then I would, so back to your question, sorry, that was a little
No
detour
problem.
there.
No problem.
I would explain the difference between desire,
Mm-hmm.
arousal, orgasm, and satisfaction.
Mm-hmm.
Those are the phases of sexual response. Both men and women experience each phase, but we experience them differently.
Mm-hmm.
And sometimes in not the same order.
Mm-hmm.
So I would make sure that when he says he doesn't have interest, he's talking about interest.
Right.
Right. So I want to first confirm that he's talking about libido or desire and not arousal, because those get, confused a lot.
Of course.
And if I can then confirm that he is talking about his desire, then I will ask a lot of questions.
Mm-hmm.
To see if I can quickly point to an organic problem. I'm not a physician, but I've been working closely with physicians for 30 years. So I know what the primary suspects, the usual culprits are that might undermine libido in a man.
Mm-hmm.
So I ask, are you taking any medication? Do you have any vascular problems? Are you diabetic? So on and so forth, heart issues, whatever. And sometimes it could be depression.
Mm-hmm.
Sometimes it could be anxiety or performance anxiety.
Mm-hmm.
It could be that they're no longer sexually attracted to their partner.
Mm-hmm.
So I go through a series of questions to determine if their complaint is what's called primary versus secondary. We also refer to that as lifelong versus acquired.
Mm-hmm.
So if he says, I just don't have interest, I want to find out, is this a change from your baseline? Is this an acquired problem that you had interest up until X, and then since X you've noticed? Or has this been gradual, or has this been a lifelong awareness that you have, that you've never sort of been as horny as your guy friends?
Mm-hmm.
Then I want to determine if it is what's called global versus situational.
Mm-hmm.
And that has to do with the context. So a man might say, I'm really not hot for my wife, but I'm extremely hot for my lover.
Mm-hmm. Mm-hmm.
Right? So that's a situational problem that's best explored with me and not you.
Absolutely.
Right?
Absolutely. That's definitely not an organic issue or physiological issue with how things are functioning. That's for sure.
Exactly. And so I in 15 minutes can run through this, and I do a pretty efficient job of kind of putting people into camps.
Mm-hmm.
The other thing I want to assess, if I can, is if it's psychogenic or psychological versus organic.
Mm-hmm.
And if I have any doubt or concern that there might be an underlying undiagnosed medical condition, I'm going to call you.
Right. Call you, meaning the urologist.
The urologist or
the
a
primary
sexual
doctor.
medicine. Yeah. Yep. I work with a couple of sexual medicine docs who are fellowship trained in sexual medicine. And so sometimes I'll say to people, I'm pretty confident that this is a psychological problem, but I would feel better if you see my guy just to rule out any potential organic stuff so we can put it to bed. So we know that you're healthy medically, and then we can tackle this from a psychosocial perspective.
Right. Well, I think you brought up a couple of really, really important points here. Not that everything you didn't say was important, but a couple of really important points that struck home with me. Number one is that differentiation between desire, arousal. A lot of guys, if they don't have an interest in it, they think that in sex, I should say, they think the answer is taking Viagra. We'll give them the solution, but that's not going to make you more interested.
It's not going to make more, and it's not going to help with premature ejaculation. a lot of docs prescribe PDE5s for rapid ejaculation, and the docs don't even seem to understand that Viagra only affects the arousal phase of sexual
Right.
response, not the orgasm phase, not the desire phase. So yeah, thank you for saying that.
Right.
Viagra it has its place and it can work extremely well, but it only works for that specific complaint.
Exactly. And the other issue that is equally as important and really important for guys to understand is that sex does not live in a vacuum. And this is what you brought up with anxiety and depression, that guys think about sex. If their desire for sex goes down, the instant translation is maybe I don't love my partner anymore. Maybe I'm not attracted to my partner, where in reality, it could be a new job. It could be stress about COVID. It could be stress about God knows what, or depression, or other more holistic
100%.
psychological concerns that they may not even be in tune to. And this is kind of where that transition goes from the doctor, the organic healer, to the psychological healer. And
Yep.
again, the sad part that I see is that a lot of guys just don't realize that. So they're never going to see somebody from the psychological, even to explore the psychological part of things, because they just don't see it as an issue. And I'm so glad you brought that up, because not everything has to do with your feelings about your partner and about the act of sex when it comes to sex.
100%.
So
100%.
I just think that was so important that you brought that up, because guys blame the wrong things oftentimes.
They do blame the wrong things often, and it's not even on their radar. Like they think, my resentment toward my wife affects my penis. Like what?
Right.
So I'm like, yeah, if you're pissed off, your penis is gonna be pissed off too,
Right.
So there's a lot of interpersonal stuff floating around that often isn't acknowledged or understood in a way that can impact sexual desire and function, for sure.
So we talked a little bit about low desire.
Mm-hmm.
A lot of guys have what they think, or what people tell them, is maybe excessive desire.
Mm-hmm.
How do you judge that? Like you said, everyone's different, right? How do you judge when desire can be truly described as excessive, and what can guys do about that?
It's so great. I love your questions.
Well, thank you.
So I've worked for a very long time with men who have what I would call compulsive sexual interest or compulsive sexual behavior. We now use the term out of control sexual behavior. You may hear the term sex addiction. It's not a term I like to use, although it's a popular term. And this gets tricky because men tend to pathologize themselves, and they tend to be pathologized by their partners and society as well. Because we live in a generally sex negative, sex shaming culture, there's an inherent little piece of distress for everyone around their sexuality. And men who are preoccupied with sex, distracted with sexual energy, who can't focus on their work, who can't sleep because they're looking at porn. They can't get through the workday without masturbating in the men's room. Sometimes they're unable to drive in their car without pulling over and masturbating, or masturbating while they're driving. And they need what's called a TSO, total sexual outlet, is a term that we use in terms of how many orgasms do they need per day, for example. And it's not like there's no magic number. I have treated men who masturbate 10 to 12 times a day. I've treated men who needed to be hospitalized because they were so rough with their penis that it was chafing or bleeding. I treated a neurosurgeon who was excusing himself from open brain surgery to masturbate because he couldn't go more than 3 hours without having an orgasm. So I think we
Right.
all would agree that that's compulsive.
I would say so. I mean, it just sounds like, I mean, the real definition there, it sounds like it's where sex isn't part of your life, it becomes your life, basically. It
I love
dominates
it. I love it. Yeah. Yep. It
you. So
affects your functioning. It impairs your ability to sleep, work, function. That's my definition. And
yeah,
that may be for this guy, it may be this particular, it may look like this. For this guy, it may look like this. They don't have to be the same, but
mhm.
it's about functional impairment. And my functional impairment and your functional impairment aren't going to look the same, but they're still both problematic.
No, for sure. You know, most guys think about excessive sex as a positive, but what the examples you bring certainly are disturbing and can really destroy somebody's life.
And
Um,
and sometimes it's unwanted.
well, I can imagine. I can
You know,
imagine.
I mean, some guys lean in and they love it and they wouldn't trade it. You know, I asked them if I could wave a magic wand and poof, you know, your compulsive sexual energy would just evaporate. Would you want me to? And plenty of guys say no, but plenty of guys say yes.
Mhm.
And some
Yeah,
men feel like slaves. The drivenness, the preoccupying quality, there's a perseverative component to it, and they feel burdened for sure. And they would love it if I could turn the volume down. And there are ways to do that.
on a high level, can you just explain like what are those ways? Just, I mean, you don't have to go into the details, but like on a high level, how do you take the situation where somebody's literally their lives are taken over by this compulsion, this desire? How do you turn that around for somebody?
Well, it's a multifaceted approach. So psychotherapy, to really understand what is the role of sex in their life, what are they trying to accomplish, what is the backstory, what I call their sexual story. So that would
Mhm.
be my role.
Yeah.
Your role, for example, would be to prescribe a medication such as an SSRI, which has sexual side effects, which we
Mhm.
actually use strategically to turn down the volume on sexually compulsive energy.
Got it.
So it's so predictable that if you give someone Zoloft or Paxil or Celexa, that it's going to make it more difficult for him to have an orgasm and ejaculate, that we actually use that medication intentionally to make it harder for a man to get to that orgasm phase,
Mhm.
so that it's more frustrating. There's much more work, much more of an investment. And because it's not as easy as it was, oftentimes that can be a deterrent right there.
Makes sense. No, it's great. It does make sense. I like the concept of that multifactorial approach, not multifaceted approach, not just hitting it with the same hammer, for sure.
And also, if it's really, really compulsive, and especially if there's a criminal component to it, for example, sexual assault,
Mhm.
we use Provera, which is a female hormone. We do it Depo-Provera, which is a intramuscular injection.
Wow.
And you may have heard of the term chemical castration.
Sure.
That's another option. Usually a high dose of an SSRI and psychotherapy and a 12-step group,
Mhm.
or reading some books and doing some workbooks. The sexual compulsivity has been shown that a group format is pretty successful, because you're
Mhm.
talking with other men who struggle with similar problems, and there's often
Right.
a lot of overlap, and so they can be a community and support each other.
That's great. So you're not alone. It's half the battle right there, and you're not stigmatized for your issue because it's not something. It's not just you. That's for sure. Now, taking if you will, I'm going to say this in major air quotes, pathological situations where it's excessive desire or not enough desire in an individual. Invariably, what you hear all the time, and especially it's a subject of jokes and movies, is what happens when whatever the man's desire level is, it's not in line with the desire level of his partner.
Yeah.
What do you do in that situation?
And that's basically my bread and butter,
Hmm.
if I may say. I mean, that is the typical. I have a new couple, they're coming in for the first time, and it's either we have discrepant interest in sex, or he's looking at too much porn, or you know, he cheated on me or she cheated on me. There's certain sort of basic things that tend to bring people into the office. Discrepancy in desire is one of the primary presenting complaints. And I really take the time I'll split the couple up and I'll take a comprehensive sexual history from each to assess both the positive and negative influences that shaped their sexual identity. That can go back to pre-puberty. I certainly spend a lot of time talking about puberty and what that was like and how they felt compared to their peers. Did they feel normal? Did they feel abnormal? I will assess whether there could be an organic component, as we discussed. I will try to get a sense of the dynamic between the two of them and see if sex is maybe being used as a currency or, as a form of power or control. And then I just try to remind them that they got married for a reason, or they're living together or coupling for a reason. And then I have a little spiel on how healthy and protective sex is, both physically and emotionally and psychologically. Often there's resentment, which can be a barrier. But sometimes people just have different appetites, right? Like you may like steak and I may like lobster. Or you may like steak a lot and I may like steak a little bit. And so there's a lot of negotiation and compromise and an attempt to nurture empathy for your partner and appreciate their point of view. There's a lot that can be done, but it's hard work for sure.
And so it sounds like it's a combination of things, but would you say it's more of, because the first part of your answer was like, I'm going to go, you talk about going into puberty and really delving into understanding why somebody's desire is high and when somebody's desire is low and why they're not matching up.
The psychosocial component of it.
Correct.
People have inherent different appetites, but often trauma or experiences can impact our sexual self-esteem, and that can, have a legacy. Go on.
And so is the answer more of, let's try to bring the partner with the lower desire up or the one with the higher desire down, or is it just a matter of compromise? Like what is or is it some combination thereof? Like what's the usual approach when you have that situation?
Compromise for sure. Sometimes I try to bring the lower partner up. Sometimes I try to bring the higher partner down, but often it's a compromise and a negotiation. And I try to help the couple have experiences that are going to feel safe for both of them. We explore parameters and expectations, and we're very, very strategic in how we set up, exercises and what's going to happen and when and how. And there's a lot of sort of pre-gaming around that sort of stuff.
Got it. Now, one other thing that you mentioned, which is becoming more and more of an issue now, is pornography, right? So I was listening to another podcast a while back where somebody had mentioned that adults in the US are probably having less sex than they've had in history.
Correct.
And a lot of the reason for that, at least attributed by, but I'm not an expert, so I'm not in my soapbox. I'm just passing along. So a big reason that they mentioned was pornography, and that pornography, the amount of pornography that is being, I don't know if the right word is, consumed, mostly by the male population, is astronomically going higher, and that pornography is creating expectations that can very rarely be satisfied in real life, and that creates a disinterest in men from reality, because they much more enjoy what they're seeing on the internet or on movies or who knows where else, but they're into that. And when reality hits, it's just not as exciting because they're almost immune to it at that point. How do you overcome that?
Yep, that's another sort of chunk of my bread and butter, if you will. men are becoming immune to what is referred to in the biz as vanilla sex,
Right.
which is, we might say conventional sex or traditional sex. And the thing about porn is that there's so much to see. It's so accessible.
Right.
So there's breadth and depth and endless supply. And you can find porn. What is it? Rule 30 something. Have you heard of that? Rule 38, 36, 62. I don't know what it's called, but basically, if you can think of it, there's porn.
Oh,
Porn.
no doubt. No
There's
doubt.
my sons told me, they mentioned a rule. Like I forget what it is. I'll have to follow up with you and let you know. But if you think of it, there's probably porn that exists.
I have no doubt about that.
Yeah.
That seems the case.
And there's so much more and more perverse pornography available. I mean, we've got rape porn, we've got torture porn, we've got child porn, we've got bestiality porn. So men are becoming desensitized to so-called vanilla sex. And the novelty of the porn boosts dopamine. Dopamine is the foot on the gas of the sexual car. So anything new and different or unusual is going to give you that hit of dopamine. And that's where that's the pleasure center or the reward center in the brain. Think like chocolate cake or heroin or whatever it is that someone might be addicted to. And it's not going to feel as exciting to have vanilla sex with your partner after watching 3 hours of porn. And there's plenty of so-called, not all porn is hardcore. And I'm not anti-porn by any means. I just want to state that for the record. I think porn can be used responsibly and in a healthy way, individually and for couples. But it is definitely changing the way that our younger generation think about sex, because they're seeing things and their brain is getting wired in a certain way. So when it's not as exciting in real life, a lot of men either can't get hard, can't stay hard, or can't ejaculate because it's just, they're not getting to that point of what's called ejaculatory inevitability, or what I say is the point of no return. They're just not excited enough. And it's causing, extreme damage in relationships. And it's a very common reason why couples come and see me, or men will come individually and say, I'm addicted to porn. I can't get aroused with my partner. I can only masturbate. So porn-induced erectile dysfunction.
Right. And again, in that situation, is your role to wean them off of the porn, or to allow them to somehow still enjoy what you're calling vanilla sex while still maintaining their porn habit, if you will?
Great question. Combination of things. So I try to eroticize vanilla sex, because vanilla sex can be hot sex if you have the right components.
Sure.
The thing I hear from men more than anything else, like in 30 years, the consistent thing I hear from men is that they really appreciate an enthusiastic partner.
Makes sense. Yes, I can see that.
And they want to be with someone who's having a good time, who's expressing that pleasure, and is sexually responsive to them. So a lot of men would say, if I could get my partner to loosen up, or if I could get my partner to be willing to do certain things, or if I could get my partner to, be more open, I wouldn't need the porn. Some men want to stop the porn altogether. Some men's partners make it a non-negotiable that the partner doesn't want them to have porn. And so then there's a lot of exploration and negotiation around that.
Mm-hmm.
I don't have a problem with men having a rich and diverse and varied arousal template. I think it's healthy.
Mm-hmm.
I just like to broaden. If there's only one pathway or two pathways to sexual gratification,
Mm-hmm.
then that person, is going to have a limited experience.
Right.
So if someone comes in and they've got a kink and they can only get off from rimming, or they can only get off from anal sex, or if they could only get off from, if their partner's wearing stilettos and fishnets, whatever the case may be, I'm a
Mm-hmm.
kink friendly therapist. And so a lot of people from the kink community and the BDSM community seek me out because it's a welcoming environment. But I want to help them broaden their arousal template so that they have more pathways and more options if that's what they want to do.
That
Some
makes
people
sense.
come in and they are very ashamed of their kink, and it feels what I call very ego dystonic, meaning there's a disconnect between their values and their behavior. And they
Mhm.
say, please help me get rid of this. I don't want to have this fetish.
Mm-hmm.
I don't want to be sexually aroused by diapers.
Mm-hmm.
Can you help me get rid of this? Or they might say, I am sexually aroused by diapers. Can you help me learn how to disclose this to a prospective partner?
Mm-hmm.
Or I'm aroused by diapers. Can you help me get my partner to participate? So a wide range
Yeah.
of agendas. And I just meet the patient where they are. I don't have an agenda for anyone.
No, that makes sense. But a couple of things that I want to mention here or bring up. So the erotification of vanilla sex, or making vanilla sex more interesting. I'm assuming that is probably the solution for the other situation you probably see a lot, which is as relationships mature, the excitement kind of goes by the wayside, and with that, the desire goes by the wayside from one or both partners, because again, it's just kind of a routine, and the spark is not there. Is the answer there the same?
Yes, novelty, intimacy, emotional intimacy can fuel erotic response, and creativity and humor and playfulness. I mean, I have a kind of list of tricks in my bag that I bring out for couples to help them stay spicy in their sexual life. Yep. And another thing, I treat a lot of people, which is becoming more and more common, is sexless marriage, sexless relationships, where couples come in and they'll say, we haven't had sex in 6 months or 6 years or 26 years. I've actually had couples come to me that have been together for decades and haven't had sex in decades.
Yeah, it's like a platonic relationship, basically.
Oh, absolutely. And they'll say, we kind of want to get back on that sexual horse, reclaim that sexual energy. And I see couples in their 20s, 30s, 40s, 50s, 60s, 70s, and 80s who have had some extended period of abstinence, and they want help sort of reclaiming that and reintegrating that into their relationship. And it's probably, I have so many favorites. I say, this is my favorite, that's my favorite, that's my favorite. But I really, really especially enjoy working with couples in sexless relationships.
Yeah, I mean, I'm sure that can be very rewarding once you help them overcome that, for sure.
And it's much easier to get back on track than one would think.
Mm-hmm.
And I like to give the clients or the patients credit, because by the time they call me, Oleg, they've already made a commitment to each other. They've already identified sex as a value in their relationship, and they're ready and they want to get back into that sexual groove.
So that is a good segue, because one thing as you were talking kind of popped in my mind a lot, is that even before going to a sex therapist, you have to have that awareness. And the harder part, especially for guys, is broaching that subject with a partner. Guys don't feel comfortable talking about what they ate for lunch, much less about kind of problems with a sexual relationship.
So
I know this.
true.
I know this is probably not a 2-minute answer, but if you had to give one piece of advice to a guy who he has the insight, he sees a real problem in the relationship,
Mhm.
how does he broach that subject with his partner?
Such a great question. First, I want to defend the guys out there because women do just as poor of a job as men do.
Well, that's good to know. There you go. That makes me feel better.
For different reasons, and it manifests in different ways. But I would say our culture at large is ill prepared and ill equipped to discuss sex.
Right.
And I don't want to just put it on the men because women are often even more uncomfortable. So I just wanted to give that little plug for guys.
And they appreciate it.
Um, we aren't taught to talk about our sexual feelings or our sexual experiences. In fact, we're taught not to. Right?
Mhm.
If you get caught masturbating, I mean, even the word caught is has a negative connotation, right? If you get
Right.
caught masturbating, then little girls who touch themselves, their mothers will make them wash their hands. They'll say that's dirty.
Right.
Men, boys who are caught masturbating are told to pray, or that they are having sinful thoughts. So the messaging from a very young age is that sex is taboo,
Mm-hmm.
and that sex is dirty.
Right.
So why would we comfortably discuss something that's taboo and dirty? It's just a setup for people to not go there.
Mm-hmm.
So I kind of do a reprogramming with people, and I facilitate those conversations. First of all, I might help them get in touch with their own sexual preferences, fantasies, expectations. Then I help facilitate a dialogue between them and their partner. And I've developed a protocol, a clinical protocol called the Comfort Inducing Sexuality Dialogue that people can read about on my website.
Mm-hmm.
That talks about why it's important to share with your partner. It's really hot and really intimate.
Mm-hmm.
And it has been life-changing for some of my couples to have these conversations in my office with my facilitation. And it's incredible what a conversation can do.
Yeah, I mean, when there's an obvious elephant in the room and neither partner can broach this, there is the elephant in the room, ladies and gentlemen. So there you go. I speak truth. So there's when that particular elephant is in the room and yet nobody's willing to describe it, you're kind of talking past each other and ignoring it, and
for sometimes years and years and years.
right.
I mean, truly, decades.
Right. And I think that the point, a couple of points you brought up with that's worth mentioning again, is that there's a couple of elements at play here. Number one,
Yep.
you as an individual have to have some insight that there is a problem, even
Yep.
from your perspective, right?
Yep.
And number
Yep.
two, you have to get an understanding as adults, as consenting adults, there's nothing bad about having sex, and it can be discussed. It's not a taboo subject, particularly not with your partner.
Especially not with your partner.
Right. And if you overcome that, I think that then all you need, which is not a small thing, is to be equipped with the tools to be able to have a meaningful conversation. And that's kind of where you can certainly help. But I think those three components are really important. It's not just a one-shot deal. There's those three components it takes a lot to be able to have that conversation honestly.
It takes a lot. Because we're having to undo cultural norms.
Yeah.
Before we can even start. And people ask me like how to talk to kids about sex, when to have the talk, when to do the birds and the bees conversation. And what I say to them is, it's not a one-time talk, it's a lifelong conversation.
Right. Right.
So I try to practice what I preach. I have 3 sons, 23, 21, 16.
Oh,
Since
wow.
they were very, very young, I've talked with them openly about their body and different sensations in their body. When they
Mhm.
were very little, if they got an erection, I would say, good boy, that means your body's healthy, you're strong.
Right.
And they were proud. They were like, yeah, I'm strong, I'm healthy.
There you
Um,
go.
and I just was not going to allow shame, sexual shame in my home.
Right.
My boys are pretty progressive. They, at times they've been quite embarrassed by my job, and depending upon their age and different
Sure.
phases. But
Sure.
now they think it's awesome, and they're super cool. And it was all their friends who would call me and come to me and say, I think my girlfriend might be pregnant, but I'm afraid to tell my mom. Can you help me?
Right.
Or
You're that cool parent that they can
I'm the
turn to.
cool mom. Yeah.
Right.
So, and I'm glad they felt safe to reach out, because they certainly didn't feel safe speaking to their own parents.
Yeah. So, one of the things that we had talked about, mentioned earlier a little bit, is about erectile dysfunction as part of kind of the arousal component, of the sexual journey there, of the phases of sex. And I had mentioned that, with guys, if they have erectile dysfunction, they answer as, well, I just need some Viagra or Levitra or Cialis, and where can I get some, and ask a buddy for some.
Yeah.
And for some men, that's true. For some men, they have, organic erectile dysfunction. Maybe it's because, they have diabetes or heart disease or other issues.
Right.
But for some men, it's what we call psychogenic. It's psychological. And one example you brought up was that, for guys that are, dependent on porn, that they can't get an erection outside of porn. And there's others as well. But how do you, as a therapist, tease out, if somebody comes to you and says, I have problems with erections, how do you tease out the psychogenic or psychological erectile dysfunction from those guys who truly have organic ED and
Yep.
need some potentially Viagra or Levitra if they don't have any contraindications, of course?
Yep. So first of all, I would turn back to what I mentioned earlier, where I make these critical decisions around classification. So I want to know, is this acquired or lifelong?
Mm-hmm.
I want to know, is this situational or global? Because not only are these things relevant for me in terms of the therapy process, but they point me in a direction.
Mm-hmm.
If a man has an acquired erectile dysfunction, if it came on suddenly, that's very different than if he says to me, well, I've always struggled with my erections. I've always been hit or miss.
Mm-hmm.
Very different treatment plan, very different prognosis.
Sure.
If someone says to me, I can't get an erection with my wife, but I can with my girlfriend, or I can't get an erection with my wife, but I can with my boyfriend, that tells me that it's unlikely to be organic, because it's context-based.
Right.
If a man says to me, I don't ever get hard, I don't wake up with morning wood, I don't, have erections while I sleep. Even when I try to masturbate, I can't get hard. That to me screams organic.
Got it.
Okay.
No, that's actually great. So situational versus constant, or contextual versus
situational, right, versus global or generalized. That to me is like the main point from which I then ask my next question. And
not to ask the question for you, but or maybe my guess is if psychological erectile dysfunction is contextual, is situational, I'm assuming the solution is to dig into that situation.
Yes.
How do you do that? How do you overcome that?
That is a big question.
It is, right?
Yeah, it is. It is family history, sexual history, current health status, current mental health status, current relationship status, former relationship dynamics, current relationship dynamics, notions about sex, stereotypes, and other things like resentment, or are you no longer attracted to your partner? Or do you have guilt? Are you cheating on your partner? So there's just a lot of data to collect.
Mm-hmm.
And then it's my job to take all that data, all those different strings and weave it into a tapestry. And then I feed back to my patient what I think might be going on. I'll make interpretations, I'll reframe things, I'll do some psychoeducation. And we go down a well, and we don't know exactly where we're going to end up, but we go down.
So if I'm catching you correctly, you're trying to take in a ton of data to understand the psychological framework of that individual, and in so doing, you're trying to find the root psychological cause for the ED in that context or in that situation, basically.
Cause or causes.
Mm-hmm.
There's often a multitude of potential causes, and I pull them out.
Mm-hmm.
It's sort of my job to take the pile of stuff and turn it into something brilliant,
Meaningful, yeah, and actionable. I'm assuming, right?
Actionable, yeah. I call it someone's sexual story.
Yeah, well, that's important because most people don't have the wherewithal, including myself. I mean, anybody really, to be able to bring all that in, because you don't even know what questions to ask yourself.
You don't know what questions to ask.
Right.
1 hour alone with you, Oleg, you won't believe what could happen.
I'm telling you, I'm gonna be a new person. Let me tell you, I have so many insights I'm gonna come. I love it. I love it. Let me bring another example in, though, specifically with erectile dysfunction. We talked about psychogenic erectile dysfunction as is, right? No organic component, right? And I think you've outlined a great solution to that, right? A, to understand when you have psychogenic erectile dysfunction, at which time you should definitely not be seeking out pills or other treatments, and B, how to work that out.
There's one caveat.
Mm-hmm.
PDE5s are the class of medicine like Viagra or Levitra or Cialis. The pill doesn't know and doesn't care if you have an organic problem or a psychogenic problem.
Right.
It works. It draws blood to the pelvic region. It's going to be a vasodilator regardless of the origin.
Mm-hmm.
Sometimes men, even with psychogenic erectile dysfunction,
Mm-hmm.
can get away with performing with a PDE5.
Mm-hmm.
And if that works and that gets them where they need to be, then that's fine.
Mm-hmm.
So I wouldn't rule out categorically PDE5s for psychogenic erectile dysfunction, because sometimes it's a confidence issue.
Right.
And if they can just get a couple successful sexual encounters under their belt, then maybe they won't need it anymore. So I just want to be clear that I don't see Viagra as indicated exclusively in organic situations. But so go ahead.
Understood. Understood. Yeah. And I think the caveat to that is, I guess the caveat to that is that you, with psychogenic ED, right? I think you'd agree that if a guy starts using Viagra, right?
Yeah.
And they don't even know,
right?
He doesn't even know he has psychogenic ED, but he's starting to use Viagra. Now he's dependent on Viagra,
yes.
And he's not getting to that root cause.
100%. So I would never encourage someone with psychogenic erectile dysfunction to do Viagra alone or in lieu of psychotherapy or sex therapy.
Right.
But the thing is, the medical doctors are writing these prescriptions like candy.
Right.
They're not screening their patients, which is why I want to applaud you again, Oleg. They're not screening their patients to tease out if there may be a psychogenic component.
Right.
They're just giving them prescriptions. And so the guys do get dependent on it. They don't ever understand what's going on, and they really don't need it because there's no underlying vascular or medical problem. And then they end up seeing me 5 years later and they're worse off.
Right. And that's why I wanted to bring that up. I do not disagree that in the right circumstances, it can certainly be used in the context of psychogenic ED. It's just a question of, you don't want to forget the real problem, right? And that actually brings up my next question, which is kind of this hybrid, right? So some guys, they have organic erectile dysfunction and they take Viagra and Levitra and they're better. They can get an erection. But now this whole process has so gotten into their head that even though organically they're fine, they're able to perform, but the performance anxiety and the sexual experience just becomes miserable for some of these guys. I'm sure you've dealt with that. What do you counsel them? How do you get them over that situation?
That's why we need to talk and
Hmm.
not just do, right? Because these things have legacies,
Hmm.
and maybe the dynamic between the couple went off track during the period of erectile dysfunction. And even though it's better now, there's still some lingering bad feeling or
Right.
insecurity. A lot of times Viagra works and men discontinue it. And I'll tell you why. Because good erections don't solve bad relationships.
Right.
And so a lot of times men will say, look, honey, look what I have for you. But their partners are so over it
Hmm.
that they're not receptive to sex. So there must be a buy-in from the partner if a PDE5 is going to be used. That's one thing that in research has shown, that about the partner's support from the beginning and involving the partner from the beginning is very protective in terms of efficacy and satisfaction.
Hmm.
But yeah, we can fix things. I treat a lot of women with pelvic pain, and I know this your audience are men, but when women have pelvic pain and then they get treated, and it's like, okay, now I can have sex. It doesn't just negate all the hurt feelings and the confusion around the period where sex was not an option. So sometimes men will be afraid to initiate sex, even though their partner's better or they're better, because there's just layers and layers of interpersonal complication. And so I think no one, and this is not just plugging my field, I think no one should get Viagra until they spend at least a half an hour with a sex therapist.
That certainly makes sense. And to that similar vein, I'm going to just do a quick public service announcement of, for those guys that are listening that are thinking about Levitra, Viagra, or frankly, any of the other medications that we're mentioning here, you have to talk to a doctor. You have to talk to a practitioner. These medications can be dangerous. They can have significant side effects. Sometimes they can't even be life-threatening. So you have to have somebody guide you with these medications and not just borrow them from a buddy or try to buy them online. That could be an unmitigated disaster. And that concludes my public service announcement.
And not just the PDE5s and the generic PDE5s, but stuff you can buy at a gas station.
Right.
Like
exactly.
Bad shit.
Right.
That, supplements and this and that and all these promises, some of the names are escaping me, but they're very funny.
Yeah.
You don't know what's in that stuff. That's not FDA approved. I mean, there's
Exactly right.
there's a lot of dangerous products out there.
Exactly right. Exactly right. And again, that's one of the purpose of this podcast, to educate guys about that, because again, everybody wants the easy fix, pop a pill, feel better. The last thing you want to do, especially in this situation, is to look for a random pill to take, because you're going to go down potentially a rabbit hole you really were not expecting to.
And I think it might be worth mentioning that the Viagra, Cialis, Levitra class of drugs are only the first phase of intervention for erectile dysfunction.
Right.
And there are plenty of men who don't respond. If they have a lot of risk factors, organic risk factors, if they're obese and diabetic and a smoker and a drinker and they have high cholesterol and they're on an antidepressant, like Viagra may not touch that.
Right.
So, as you know, as a urologist, if that fails, then there's the next sort of level of care, which would be injections or suppositories, or maybe a vacuum pump, or a penile implant, or revascularization surgery. So I just want men to know who haven't come in to see you that there's more intervention than just pills.
For sure. For sure. And I think that that's really an important point, that there's a continuum of treatment, not just kind of, it's not all or nothing. Well, I think that from that standpoint, I think that's a great place to pause. I do want to ask you a couple more questions, more generally. One question I want to ask you is, if you had, and this is kind of a loaded question, I guess, but if somebody asked you as a sex therapist with over 30 years of experience, what would you say is the one true key to success I'm going to butcher this now. What is your one true key to success for maintaining successful sexual relationships?
Value around sexual health.
Mm-hmm.
An honest, earnest belief that sexual health is important in your life, and something to be celebrated. If I had to say one thing.
That's important. I think it's an important thing. That goes back to the thing that sexual relationship sex should not be stigmatized, and it should be embraced as an important part of a relationship, not that hidden part, that's just kind of, under the table, if you will, behind the screen. And the other question I'm going to ask you, this is maybe completely unrelated to your field. I always ask my experts because, at the end of the day, the purpose of this podcast it's called Better Man Clinics, and it's really to help guys get better in many different ways and to live their best life. So everyone I have on here, all the experts I have on this podcast, are obviously successful in many facets of their lives. And what I ask them always is, because I like to learn this too, what is your recipe for living your best life?
For me, it's gratitude.
Mm-hmm.
For me, it's being intentional about what is meaningful to me, honoring my values, and just being very, very grateful.
It's funny, because that's the number one answer that comes up from successful people that I ask that question. And I don't think it's a surprise, because I don't know if you know this, but there was a study done a few years ago where they interviewed thousands of people. It was a study on happiness.
Huh.
And they studied people about, what makes people happy. Mm-hmm. And they looked at the usual things like money and family and all this stuff, and everything played a role, but by far and above everything else was gratitude. These people were grateful, and that was the key to happiness in their lives.
Absolutely.
So what better place to pause than there? Kimberly, thank you so much for joining us. I know I learned a ton, and I would love to have you back to explore some of these topics in a little bit more depth. I know we've just begun to scratch the surface. So thank you so much for joining us. And
my pleasure.
Thank you. And thank you for everyone listening and watching. We appreciate you. And as we say in Better Man Clinics, your best self is a journey and not a destination, and use every single day to get just a little bit better. We will see you next time. Thank you.